Understanding anatomy is fundamental to the rational practice of ultrasound-guided anesthesia and the success of the wall abdominal blocks. The outermost muscle of abdominal wall is the external oblique muscle inferiorly attached to the inguinal ligament, superiorly attached to the 5th through 12th ribs. Internal oblique muscle is attached to the iliac crest and the thoracolumbar fascia, superiorly attached to the 10th, 11th and the 12th rib. In the midline the muscle encase the rectus abdominis and attached to linea alba. The transversus abdominis muscle. It forms anteriorly a fascia, join aponeurosis of internal oblique and pass posterior to rectus abdominis. Attached posteriorly to lumbodorsal fascia. Attached inferiorly to inguinal ligament and iliac crest. Attached superiorly to 6th and 12th ribs. The rectus abdominis muscle. Attached inferiorly to the pubis. Attached superiorly to external surface of the costal cartilage's 6th and 8th ribs. From outside to inside the different layers are skin and subcutaneous tissue, rectus abdominis, external oblique muscle, internal oblique muscle, transversus abdominis muscle, transversalis fascia, preperitoneal fat, peritoneum, abdominal content. The nerves that innervate the abdominal wall arise from the ventral rami of the T6 to L1 spinal nerves. These nerves wrap around body to provide innervation to lateral and anterior abdominal wall. The dorsal branch of spinal nerves innervate the muscle and skin of the medial back. The ventral branch of spinal nerves innervate the chest and abdominal wall. The two main branches are lateral cutaneous branch and anterior cutaneous branch. External oblique and internal oblique muscles are removed. The terminal portions of the intercostal nerves that innervate the majority of the abdomen. The most common landmarks to remember are xiphoid by T6. Umbilicus by T10. The L1 and T12 forms the ilioinguinal and iliohypogastric nerves. It is important to consider the patient information management. All patients are clearly informed. Info are provided by anesthetist patients during preoperative consultation. In addition, ultrasound-guided anesthesia is typically performed by anesthesiologists and pain specialists in a procedure room or within the operating room with respect of 10 steps of safety management. Visualize key landmark structures. Identify nerves. Confirm anatomy. Safest needle approach. Aseptic technique. Visualize needle under real time. Consider another confirmation technique. Small volume of anesthesia. Optimal spread of local anesthesia. Aspiration monitoring assessment of resistance. This block typically is performed with the patient in the supine position. The iliac crest and costal margin should be palpated and the space between them in the mid-axillary line identified as the initial transducer location. The 3 muscle layers should be identified. Sliding the transducer slightly cephalad or caudad will aid the identification. Once the transverse abdominal plane is identified, the needle is inserted in plane in a medial to lateral orientation. The needle is guided through the subcutaneous tissue, external oblique muscle and internal oblique. A pop may be felt as the needle tip enters the plane between the two muscles. The block of the iliohypogastric and ilioinguinal nerves is done in supine position. Palpation of the ACEs provides the initial landmark for transducer placement. The three muscle layers should be identified. The nerves should appear as hypoechoic ovals between the internal oblique and transversus abdominis muscles. Moving the transducer slightly cephalad or caudad to trace the nerves can be useful. A skin wheel is made on the medial aspect of the transducer, and the needle is inserted in plane in a medial to lateral orientation, through the subcutaneous tissue toward the ilioinguinal and iliohypogastric nerves. A pop may be felt as the needle tip enters the plane between the muscles. With the patient in supine position, the skin is disinfected and the transducer placed at the level of the umbilicus immediately lateral, in transverse position. Color Doppler can be used to identify the epigastric artery so that their puncture can be avoided. The needle is inserted in plane in a medial to lateral orientation, through the subcutaneous tissue. After negative aspiration, local anesthetic is injected to verify needle tip location. The patient is in the lateral position. A low-frequency convex probe was vertically attached above the iliac crest. After recognizing 3 layers of abdominal wall muscles, transversus abdominis is traced more posteriorly until the transversus aponeurosis appears. Quadratus lumborum is usually identified medial to the aponeurosis of transversus abdominis muscle. Needle was inserted in the plane from the posterior edge of the convex probe through the quadratus lumborum in an anteromedial direction. In the lateral quadratus lumborum block, the needle tip was placed at the anterolateral border of the quadratus lumborum at its junction with transversalis fascia, and the local anesthetic is injected. In the posterior approach, the posterior aspect of the quadratus lumborum muscle is confirmed, and the needle tip was inserted into this aspect of the muscle. Intramuscular quadratus lumborum block, the needle tip was advanced until it penetrated the fascia and is inserted into the muscle.